We know what happens during acute inflammation from our previous video, but what actually tells the blood vessels to dilate and signals the WBCs to rush to the site of an injury? Who gives the command for all these events to occur? That's exactly what chemical mediators of acute inflammation do, so let's get started. Welcome back. Previously, we explored the vascular and cellular events of acute inflammation. Today, we'll take the next step and understand the chemical mediators responsible for those events in detail. And if you haven't subscribed yet, please consider subscribing to the channel. Also, stay with me until end of this lecture because I will be sharing a quick eye-healed example slide that will help you revise the entire topic in just 1 minute. Chemical mediators are endogenous molecules that are released rapidly following a tissue injury or any infection. Their primary function is to coordinate the inflammatory response. Some of them are preformed and stored, while others are synthesized only after the stimulation. They act in extremely small concentrations, have a shorter half-life, and produce some local effects, and also exert their actions by binding to a specific receptors on target cells. This ensures that inflammation remains controlled and targeted. It could be classified based on their source. Among cell-derived mediators, some of them are preformed and stored in intracellular granules, such as histamine, serotonin, and lysosomal enzymes. These are released immediately after injury, while others are synthesized only after stimulation, which includes prostaglandins, leukotrienes, platelet activating factor, nitric oxide, and several cytokines. The second major group is the plasma-derived mediators, which circulate as an inactive precursor protein and become activated during inflammation. These include the complement, kinin, coagulation, and fibrinolytic systems. In addition, certain extrinsic mediators such as bacterial toxin and venoms can also trigger the inflammatory responses. Let's look at the overall picture of major chemical mediators at a glance. Histamine mainly causes vasodilation and increased vascular permeability, whereas serotonin has similar vascular effects. Next comes the prostaglandins, which are responsible for pain, fever, and vasodilation. Leukotrienes promotes chemotaxis and bronchoconstriction. Platelet activating factor contributes to platelet aggregation and increased permeability. Cytokines regulate endothelial activation, also systemic responses like fever. Nitric oxide produces vasodilation and also has antimicrobial activity. Let's begin with histamine. Histamine is the earliest and one of the most important mediators released during acute inflammation. It is stored mainly in mast cells but also found in basophils and platelets. Now let's visualize what happens when this chemical mediator is released.
Meet the chemical mediators. Released during injury, they trigger inflammation. They dynamically expand vessels, allowing defense cells to escape.
As we saw in this video, once the histamines are released, it produces vasodilation and increases vascular permeability, allowing the plasma protein and leukocytes to leave the circulation. They act within seconds. In contrast, prostaglandins and leukotrienes are synthesized de novo from arachidonic acid after cell activation. Besides vascular effects, mediators can also affect the airway by causing bronchoconstriction and mucus secretion, particularly leukotrienes. Systemically, mediators like prostaglandins contribute to pain and fever. Many important inflammatory mediators are not stored in cells. Instead, they are synthesized from membrane phospholipids through the arachidonic acid pathway. So let's visualize this pathway.
Phospholipase A2 releases arachidonic acid, initiating two routes. The COX pathway produces prot and thromboxanes, leukotrienes, causing bronchoconstriction.
As we saw in this video, COX pathway produces prostaglandins and thromboxanes. Prostaglandin E2 is responsible for pain, fever, and vasodilation. PGI2 causes vasodilation and inhibits platelet aggregation. Thromboxane A2 promotes the vasoconstriction and platelet aggregation. LOX pathway produces leukotrienes. Leukotriene B4 is a potent chemotactic factor that attracts neutrophils. Neutropene C4, D4 and E4 causes bronchoconstriction, increases vascular permeability and stimulates mucus secretion. Now let's clinically correlate the drug targets in arachidonic acid pathway. This pathway is clinically important because many anti-inflammatory drugs act here. Corticosteroids inhibits phospholipase A2, preventing the formation of arachidonic acid and thereby reducing both prostaglandins and leukotrienes. NSAIDs inhibits cyclooxygenase, reducing prostaglandin synthesis and relieving pain, fever, and inflammation. Xylutone inhibits LOX pathway, while montelukast blocks the leukotriene receptors, making these drugs particularly useful in bronchial asthma.
Corticosteroids inhibit phospholipase A2. NSAIDs like aspirin and ibuprofen inhibit COX. Xylutone inhibits 5-LOX. Montelukast blocks leukotriene receptors.
Let's connect these mediators with the inflammatory response. Tissue injury is first recognized by resident cells such as macrophages and mast cells. They release chemical mediators which initiate the vascular response through vasodilation and increased permeability. These mediators then promote leukocyte recruitment by facilitating migration, rolling, adhesion, diapedesis, and chemotaxis. Finally, they activate tissue responses including phagocytosis and microbial killing. Once the threat is eliminated, anti-inflammatory mediators help terminate the inflammation and promote tissue repair. If you found this lecture helpful, don't forget to like, share and subscribe. Thanks for watching and I'll see you in the next lecture.